I would like to welcome you all to today's special OC3PR webinar. Today's topic is a little bit outside of our typical critical care focus, but it's incredibly important as it impacts how we deliver care to our patients, both directly and indirectly. We're going to be exploring the world of public health, including their roles and responsibilities. I will freely admit that I've already learned a lot about this topic in our preliminary talks with our guests today. As is often the case, there are issues and implications that are not always readily apparent to everyone on face value. Today's webinar is sponsored by Critical Care Services Ontario. Its goal is to help provide health professionals with the skills and knowledge to improve the care they provide to critically ill patients. Today's presentation, like previous OC3PR webinars, will be available on the CCSO website and their YouTube channel. Today, we're using a different Zoom platform, so bear with us. Remember, there may be glitches or problems, but this isn't our full-time job. As before, questions can be submitted, but with this new platform, they are submitted directly to the Q&A feature directly at the bottom of the screen. Today's questions will be fielded by Dr. Jose Terrio, who's a member of the OC3PR committee. When that committee meets, we review the comments that we receive, so we certainly value your feedback. And we take those comments seriously, along with the input we receive from other health professionals to help identify topics or issues we believe are important or impacting critical care. It is with that background, along with the fact that we do care for patients, that we believe that it would be valuable to explore the issues surrounding public health and its impact on our healthcare system, all with the emphasis on the delivery of critical care, but also acute care. To explore this topic, we are delighted to have with us today Dr. Kieran Moore, Ontario's Chief Medical Officer of Health since June of 2021. Prior to this, Dr. Moore served as the Medical Officer of Health for the Kingston region from 2011 to 21. He is also the Medical Officer of Health for the Department of Emergency and Family Medicine at Queen's University and was the Program Director of Public Health and Preventative Medicine at Queen's. He received his medical degree from the University of Ottawa and is certified in family medicine and emergency medicine from the College of Family Physicians of Canada. He completed a fellowship sanctioned by our Royal College of Physicians and Surgeons of Canada in public health and preventative medicine. He also has master's degrees in disaster medicine and public health, as well as has his physician leadership and diplomas in sports medicine, tropical medicine, and hygiene and humanitarian assistance. If that's not impressive enough, Dr. Moore has practiced as an emergency room physician in some of the busiest emergency departments in Canada. And as a medical officer of health, he carries a badge. So I'm going to behave today. The objectives of today's webinar are to better understand the skills and competencies of public health practitioners and local public health units. It will outline the role, legislative responsibilities, and expertise of the Chief Medical Officer of Health and its office. Finally, it will describe how this office has worked with the health system during the COVID pandemic. Dr. Moore, Kieran, thank you again for coming to speak with us today as the Chief Medical Officer of Health. I truly appreciate it and look forward to your presentation and the discussion afterwards.
Well, thanks very much, Dave, and very much appreciate the opportunity to speak to such a robust group of our critical care partners. So honored to be invited to present. Next slide. As part of a land acknowledgement, I'd like to start by honoring the land that we are on, which has been the site of human activity since time immemorial. It is the traditional territories of the Huron-Wendat, the Anishinabeg, the Chippewa, the Haudenosaunee Confederacy, and most recently the Mississaugas of the Credit River First Nation. So I am in Toronto. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish and One Spoon Wampum Belt Covenant, are agreements to peacefully share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. We are mindful of broken covenants, and we strive to make this right with the land and with each other. So thank you. Next slide. Just as a disclosure, as David has said, I have worked in emergency medicine for a long period of time, but I'm now a salaried employee of the Government of Ontario And I will not be recommending, this is a different talk for listeners, not recommending any specific treatments and or discussing any specific medical procedures during this presentation. I have received grants and have been the director of the Canadian Lyme Disease Research Network through CIHR funding and other research funding through PSI, etc. And recently, before becoming the Chief Medical Officer of Health, received a grant to review the epidemiology of Lyme disease in Canada and for vaccine development against Lyme disease. Next slide. So as Dave had said, three major objectives, really to orient you to what your local public health unit does and what public health practitioners, what their skill sets are, outline the role. So we do have badges, we have legislative responsibilities, and you've heard section orders, letters of instructions being put in play differentially across Ontario, and to explain some of those responsibilities. And thirdly, I'd like to review how we've tried to collaborate with the healthcare system partners throughout. And I think you've heard one of our main objectives has been to protect the healthcare system so that we can provide the right care to Ontarians at the right time and at the right place. And that has been a key mantra for us over the last 2 years, knowing that this virus wants to surge and spread very rapidly and cause morbidity and mortality in our communities. Next slide. A big reason I accepted is just simply from my heart to say thank you to all of you who are online today or listening later for all the service you've done to your communities, the care you've provided, the long hours, the stress you've endured. This has all been new to all of us in terms of a new virulent virus that spreads rapidly, threats to your family, to your personal health, and potential workplace exposures. And I know many of you have been working in a stressful environment, doing aerosol generating procedures, and counseling so many families that have lost loved ones. And from my heart, thank you for all you've done and will continue to do to protect Ontarians. This was my major reason to present today, was to personally thank all of you for the work you do. Next slide. So just to review public health practitioner skill sets, next slide. It's very important to understand public health is broad. It is an art as well as a science, and you're seeing internationally, nationally, how this art can be applied in risk communication, for example, with Bonnie Henry or Fauci in the United States being excellent risk communicators, and how they have to balance the use of science, and how that is not always applied in jurisdictions globally to protect the health of the population. But it is an art and a science, and the goal is multi-pronged. We try to educate members of our community. We try to forge and create policies that protect the health of individuals. And as you've seen, do research for various diseases of interest and clearly prevent injuries. And so if you had to remember, it's the rule of P's. We try to protect through legislation, promote health, through the Ottawa model of health promotion, prevent illness, mainly through immunization or primary prevention strategies. And also a key component of our work is health equity, making sure all members of our community have an equal opportunity, an equitable opportunity for health across the life continuum. Some of our foundational skills, so if a surgeon or yourselves have intubation skills and central line skills, our skills are surveillance and epidemiology. Those are foundational to our ability to protect our populations, but to do that, we need good, reliable, and valid data, not always available to us to guide policy and decision making. And foundational as well to public health is the emergency preparedness cycle of mitigate, prevent, prepare, respond, and recover. And hopefully, we're still responding across Ontario differentially to COVID-19, but hopefully you're seeing the light that we will have a period of recovery where we're moving into a new world where the virus is in a low endemic state, probably will become a winter respiratory pathogen, and we'll have to prepare the health system annually for any potential rise in cases, along with all the other respiratory viruses that have been held in stay by our masking and distancing and hand hygiene. So as you know, influenza is typically causing havoc in our health system at this time of year. No influenza, given hand hygiene and masking and the good match with the vaccine. So we want to continue to work with our health system partners, including this audience, for next winter's respiratory virus season. And we're already starting to think through some of that work. Next slide. So as an intensivist group, you nurses, physicians, you walk in to see your patient and you look at their vital signs. So you don't have to tell you heart rate, respiratory rate, ventilation settings, O2 saturation, central pressures, intracranial pressures. As a population health doctor, though, I have 14.7 million patients that I care for across this province, and I need access to relevant, timely data that will inform my decision-making on a daily basis. And I want to let you know that the data that you provide to us through the Canadian or the Critical Care Services Ontario is essential. And it's the first thing I look at every morning is the total number of patients in your intensive care unit settings across Ontario. I look spatially and through age groups at the different admission patterns, your length of stay for patients, how many are requiring ventilation, and then we huddle and start reviewing our immunization strategies. But it starts with looking at the vital signs, which include percent positivity, how many people got tested, what's our vaccination, first, second, third, and fourth doses, and overall, how many patients are admitted to the hospital with or as a result of causative of COVID-19. So I can't thank the Critical Care Services Ontario enough for on a daily basis for the last 2 years, providing us with robust, meaningful data. And I want to let you know that it is the foundation to our response by monitoring this data on a regular basis. Next slide. As well, Dave mentioned, you may not be familiar with the training for a public health physician. I was a program director. Typically, we have 1 or 2 clinical years, and some physicians do a CCFP, so Canadian College of Family Physicians certification, in their first 2 years. Some would just do communicable disease in their first year, which is absolutely acceptable. All of us have to get trained in the foundational skills of epidemiology and hence do a Master's of Public Health or equivalent training for 1 full year. And then our residents would rotate at an international with the WHO, CDC, Public Health Agency of Canada, a national level or provincial level and or a local public health level. And they build expertise in environmental health. So some will become experts in the built environment. Some will become experts in foodborne transmission. Some will concentrate on health promotion. Some will concentrate on surveillance, and that's one of my foundational skills is health system surveillance. So we monitor all hospitals for all admissions in real time across Ontario. All emergency department visits are monitored in real time the second they happen, and it's relayed to the Kingston Health Unit where we have a real-time surveillance capacity. Some also will be experts in public health emergencies at a population level. And certainly all of our residents got great training, sadly, over the last 2 years in public health emergencies, and potentially that was overcoming some of their exposures, experiences in other domains of our specialty. Next slide. Next slide. So there is a depth and a breadth to public health programming. So your local public health agency will have programs across the life course, starting in preconception, conception, all the way through to protect families, to give all children the same and best start in life. We work on the built environment. We work on the air you breathe, the water you drink, the food you eat. All public health programming can concentrate on all of those domains, as well as preventing illness. As you know from our robust vaccination strategy in Ontario, we have one of the highest rates of protection of immunization of any province in the country. As well, we work on health promotion, disease prevention strategies on tobacco, alcohol, opiates, accident prevention, etc. Next slide. And we have an intersection between the healthcare sector and governments, given that our boards at a local public health agency level are municipally controlled. They have municipal councillors on them, so they're always embedded in the local governments with feedback from our municipal partners with provincial appointees. So that is one of the strengths of local public health, in that it truly is able to use resources of municipal governments like our arenas, facilities, and staff to help provide robust immunization responses and or give assessment centers space in which they can operate as well at a community level. And we interact with all health system partners, including nationally with the Public Health Agency of Canada, but with long-term care, retirement homes, acute care, and primary care. And given the governance in Ontario, some of these relationships are difficult to maintain or sustain, and I'm sure there'll be many lessons learned as we have time to reflect upon the last 2 years and build a more robust health system going forward. And whether this model stays intact is a great question going forward. Next slide. So I have a small office of physicians, 5 physicians with 2 consultants working in a central office. We liaise with our local autonomous boards of health, Toronto, Ottawa, Peel, you know, the 34 of them, all with autonomous medical leadership that can put in orders for their community, but best protect the health of their community, often in consultation with us. But from a numbers vantage point, the rubber hits the road in the local public health agency. They are the ones that make things happen. Ministry provides policy direction, typical of government, and Public Health Ontario, you may have heard, is our scientific advisors. So that's a basic orientation. Public Health Ontario, scientific advisors, small central chief medical officer of health, where we try to work collaboratively, communicate and coordinate to have a public health response that's robust. Next slide. And there's 34 of us. In terms of the overall health system budget, 50 billion plus, expanding given the strain of COVID, around 1 billion goes to local public health agencies. So a very small percentage of the overall health budget is in health promotion, disease prevention, health protection. And we have roughly 6,800 staff distributed across 34 health units. And the staff include dental hygienists, because we run dental programs. They include epidemiologists, public health inspectors, nurses who are doing the immunization or healthy baby, healthy children programs, epidemiologists and data experts. All of them, it's variable given the size of health units. Some health units have 34,000 population that they care for. Toronto would have 2.7 million people they care for. So the sophistication of the workforce in each unit is variable, but we work collaboratively as well together. Next slide. My position is appointed by government. It's typically a 5-year term, and I have 2 hats. I report to the Deputy Minister as an Assistant Deputy Minister of the Public Health Division, as well as directly to the Legislature as the Chief Medical Officer of Health. I have statutory powers that allow me to write orders at a population level called class orders, where we mandate masking in public spaces, for example, and or I can write directives to health systems. So you've heard of all of the directives on certain mask wearing, infection prevention control recommendations, as well as Directive 2, most recently, where we've asked to curtail certain activities within hospital to ensure ICU capacity for all patients that was necessary in this last last several weeks of January, but they have to be timely and they have to be removed in an efficient and effective manner as well. And then we also are risk communicators, all 34 of us, risk communicators to the general public. Next slide. So these are some of the legislative powers, whether it's a small drinking water system, rabies immunization, how to care for public pools, how to protect the food you eat for personal service settings, how to ensure our tattoo centers follow infection prevention and control. All of those are under the large umbrella and mandate of public health. So you may have thought we just immunize or we just do communicable disease control, but we do broad community-based activity, including activity related to the building code, Healthy Menus Choice Act, Smoke-Free Ontario is under us, cancer prevention strategies as well. Next slide. Next slide. So it's been a long journey the last 2 years where we started in putting in major declaration of emergency in March of 2020, and it's been a journey of 5 major waves across Ontario, differentially experienced across Ontario as well, and we've had to work collaboratively as a health system. Certainly in Kingston, we absorbed many patients that required intensive care during the first and second waves as the high-density urban settings of Toronto and Ottawa had rises in cases, and very much need to maintain that collaborative approach across all of our health system in the coming months as well. As you've seen, we've tried to reopen multiple different times as we've dealt with Alpha, Beta, Gamma, Delta, and now Omicron. January 5th, sadly, we had to put in further public health interventions of 2022, but for a time-limited fashion, simply to protect your capacity to care for patients. And I think we did that successfully. We never went above the 100% capacity of the hospital system, nor of the intensive care unit setting. I don't think you ever were above 80% capacity at any given time. And now that we're on the descent, it's time to review many of those. We reviewed the measures at a population level. Now it's up to review Directive 2 and its implications for the care you provide. Next slide. We also look at real-time data on a daily basis, but also have internal modeling and modeling through the Science Advisory Committee that gives us some insight in potential projections and range of scenarios for the future, and they inform some of our public health measures. And as you know now, our numbers are looking better. We're on the descent, and so too is the United States, United Kingdom, very rapid descent in requirement and need given the large population exposure to Omicron for critical care services, and hence it's time to review any directives that are in play and to work with Ontario Health to ensure maximum utilization of the intensive care unit for other purposes as well. But I do think we've successfully mitigated and prevented a surge through the public health measure from January 5th to the 31st. Next slide. Again, this is the data we look at on a daily basis, and absolutely understand now the length of stay is going up, and that's normal at the end of a wave to see patients with complex end organ issues, including ongoing need for dialysis, et cetera, to increase your length of stay within your facilities. But those are some of the metrics that we follow on a daily basis, and we look at it in time, but also in space. So across the health system, the number of patients ventilated versus admitted with COVID as causative. So these are key metrics. Again, thanking you for providing us with this data and for providing the care that these epi curves illustrate. Next slide. As well, we monitor our vaccination strategy, given that I think all of you online today want to prevent admissions to hospital. And certainly, if you have an opportunity to promote the third dose strategy, we know a third dose of mRNA vaccine significantly protects against severity of illness, bumping up from around an 80% with 2 doses to somewhere between 88 and 95% protection against severe. And you're seeing it day in, day out, 10 times higher risk of hospitalization for unvaccinated versus vaccinated. And we all, as healthcare providers and administrators, have an obligation to continue to promote our robust immunization strategy. I'm happy to say we have over 83% of our 70 and over population now with a third dose, but we shouldn't be stopping there. We should still continue to promote vaccination with over 31 million doses provided to Ontarians. And we'll be releasing further third dose strategies for other younger populations in the coming days and weeks. Next slide. I did mention just briefly about the directive number 2, which does have an impact on the acute care sector and on the work that you do on a daily basis. Now that we're on the descent, I think there'll be an announcement today, very soon, about removing some of the parameters associated with Directive 2, and we will be reviewing all of the directives that we have made to the acute care sector, and you can incorporate them into your internal guidelines for all of your hospitals if you're in agreement with them. But directives are always made to be time limited and responsive to a threat to the population, and now the threats diminishing in the coming weeks and months. We will review all directives that are in place and ask you to incorporate them into your practices. Next slide. As well, I've had questions from Dave about the infection prevention and control. So there is a hub and spoke model, sometimes run by a hospital, sometimes run by a health unit. So this is the Thunder Bay District Health Units model, where they're working with IPAC North, the hospitals, all of the ministries that have congregate settings, at-risk settings in them, long-term care and retirement homes, and with the remnant of the LHIN, so Ontario Health, to create a standard approach to infection prevention and control. I understand that some of the knowledge translation activities are difficult to have standards across all of these partners, but that is the goal, and it is a journey that needs to continue given the, as we've all realized, the significant importance of infection prevention and control. This office doesn't have any direct oversight except to write directives in that domain, and Public Health Ontario provides the scientific advice for infection prevention control guidance. Next slide. As well, Dave had asked about the transfers to long-term care facilities. Absolutely understand that ALC patients are becoming an increasing occupation of hospital beds, and we are keeping Directive 2.1 in play to ensure that we're trying work as a system to allow patients to move across the system, obviously with consent and consultation. And if there are outbreaks associated with the receiving or the sending facility, sometimes public health is involved, but I would say the vast majority of declines of transfers are for operational reasons and or the patient consent issues. Vast majority of public health units are permissive of transfers, given that we know the acute care sector environment and the antibiotic resistant organisms and the COVID transmission and number of outbreaks in acute care facilities does pose a risk to frail elderly. And I personally have never declined a transfer when I was in KFLA to a facility, given that caveat that I did believe it's safer in a long-term care facility. Next slide. And just to quickly review equity, the Ontario approach through our vaccination strategy, through our provision of oral outpatient antiviral therapies has always been one of equity, knowing that equal access doesn't guarantee same access. And we've tried to apply this across the health system. And I think we've had significant success with our vaccination strategy of having equity, given that we put that extra work, so more boxes to lift some individuals up to be able to access vaccine. That has happened through our last mile strategy, through our mobile strategy, through working with at-risk communities, through working with synagogues and mosques and churches to ensure access and communication is happening at a local level. And this is a proportionate universalism, or the direction towards equity is one that you see every single day. I am sure you're seeing that the most disenfranchised members of our community have worse outcomes. And this is something near and dear to all public health's heart, and how to provide equity and health outcomes. And it is a journey. It's not something that will happen quickly. It's generational. Next slide. As well, I'm sure you've had to deal with ethical considerations, and we have used our ethics consultants on the vaccine prioritization, which allowed through reciprocity, ICU workers, emergency workers, first access to vaccine, as well as testing and PCR access. And we've also worked with you on if we had limitations in access to intensive care, how would we provide care in those settings, as well as the use of therapeutics now with Paxlovid available across Ontario. Reluctantly, we've had to put in public health measures, including restriction of certain businesses at times, and those always have to be time limited and reviewed on a regular basis. And that's what we're doing today, is reviewing any further public health measures that need to be continued and reporting to government. So I'm sure you've been dealing with some of these issues like we have at a population level. Next slide. Just this slide goes along with our desire for equity. So this is a map of the Southeast from Belleville all the way through to Kingston to Brockville. The darker the color is the lower the income, lower educational attainment, and lower employment status. And the lighter the color is higher income educational attainment. And you'll see a 10-year differential in life expectancy across this. These areas, dissemination areas of populations, and I'm very confident the vast majority of your patients come from the most marginalized areas of the community, and will be, if you're coming from those areas, you're dying younger, you're coming in with a higher burden of chronic disease, and certainly these are some of the major population issues that we try to concentrate on at a public health level, is how to have health equity. And the pandemic has clearly shown there and potentially exacerbated health equity issues, given the employment, closing of business, employment status, and impact on the economy, and mental, physical, social well-being of individuals. Next slide. And as a result of trying to work through health equity, we looked and monitored high priority communities using those types of mapping tools, and did community outreach and education, improved access to testing and vaccination in those communities, also access to treatments, and wraparound supports, often with CHC partners, often with community organizations, to try to ensure improved health equity outcomes in those communities. And from a vaccination vantage point, we now have equity. If we wouldn't have that red to yellow dispersion and color codes across a map of Southeast, all areas have almost equal vaccine coverage, whether you're the most disenfranchised, lowest income, or highest income. Next slide. And certainly we've tried partnering with our First Nations, Inuit, Métis communities with the goal of integrated care with our Indigenous partners, and the remote immunization strategy that was coordinated through the Immunization Task Force and Homer Tien, I think showed that robust partnership where our First Nations, Inuit, Métis got their first doses, second doses, third doses in a prioritized fashion, and had rapid distribution in partnership with our Indigenous communities. And I'm very, very proud of that work. Next slide. Next slide. So I hope you're hearing the data is looking better, and I'm sure it's it's differential, acknowledging that across Ontario in terms of the Omicron activity at present. But many of you will be seeing that you have less patients in your ICUs, less stabilizing number of patients being intubated. And so we can start looking at moving from response, so adrenal mode, to hoping for recovery, and hence the review of Directive 2, and then plan for ongoing readiness against a new strain and or any resurgence resurgence of the current strains in the 22-23 winter season. And we certainly have a lot of backlog to catch up on in terms of procedures. And that's an issue we'll be working with Ontario Health on at a local level as well as a provincial level. And then there'll be the traditional reviews of how we did from a health system vantage point, public health vantage point, that will help us forge a direction forward. And I'm fairly confident those will start in the spring and summer with recommendations to government for the fall on any further structural changes we need in the health system. Next slide. So thank you again for the opportunity. Thank you for the work that you've been doing in the last 2 years, taking care of patients in a very difficult circumstance. I hope now you have a better understanding of public health structure in Ontario, public health physicians' roles, responsibilities, and education, some of the legislative responsibilities we have, and how the data that you provide to us on a daily basis is so important for us making public health policy decisions and recommendations to government. And I'll stop there, Dave, and thanks again for the opportunity.
No, thank you, Kieran. And you know, I think we'd be remiss not to recognize how well the Kingston bubble Frontenac Leeds area was during the first 4 waves, at the very least, seemed to be spared. And I think that's due in certain part to your leadership that you provided there during the first part of the first waves. And I am very sympathetic with your position. It doesn't matter what you recommend. There's going to be a group that is certainly wanting the exact opposite. So it's a bit of a no-win. And I'm going to start with Dr. Theriault, who's going to follow up on the area that you began with, or you included in terms of IPAC, as well as some other areas, because certainly I think that's what we look at. And then we have a couple other questions for you. Jose?
Thank you, Dave. Thank you, Dr. Moore. This was certainly an enlightening presentation on to consider the breadth and the responsibility across so many sectors. And I think this is what we forget sometimes from our little lens of, critical care, where we're directly involved with patients. But having been part of our critical care command table now for almost 2 years, it certainly has been enlightening for us to see all that and understand behind the scenes the work that you do. So I would just want to follow up on some of the IPAC measures. And as you know, we look towards IPAC to guide us on our day-to-day measures and protection when we take care of those patients. And I was wondering if you could comment, or your thoughts on the future of IPAC. As you mentioned, try to work towards standardization across our province. And I think through our critical care command table, and when we started moving patients all across the province to help load share, we did realize that some of these IPAC measures were quite different from one region or locally as we move these patients. And I was just curious to see what your thoughts are on the future of this and how you see that evolve over time. Thank you.
Oh my, what a complex question, and thank you for it, Jose. I think we've realized infection prevention control is foundational to the protection of the health system, and if done properly, can mitigate the spread and outbreaks within a facility, and nowhere have we realized it more importantly than in long-term care facilities. So, and I think we've realized the deficiencies in long-term care facilities in terms of maintaining knowledge base. And so I think the hub and spoke model of having a strong central hub that maintains the standard, that links with all other hubs within Ontario, and then supports whether it's a shelter, a long-term care facility, a retirement home, other smaller hospitals, in maintaining that standard knowledge translation activities, access to consultation basis is going to be very important going forward and is a key lesson learned for our system. Whenever you let your guard down with infection prevention control, AROs are going to want to come back, and or viruses in particular. We'll have to be very well prepared for the respiratory viral season for 22-23 if we don't have masking, a good hand hygiene and distancing that's maintained. I see influenza, para-influenza, all of the respiratory pathogens wanting to come back and infect individuals within all of those vulnerable settings. So along with COVID. So big lessons learned. PHO will maintain the science of infection prevention control. Will bring together Ontario's best experts to set the standards, and then the hub and spoke model, which will continue to be funded, will be the means by which we have knowledge translation, consultation, hopefully standardization. But I think it needs ongoing investment, nurturing, and we've started the KT activities to ensure best practices are adhered to across the continuum, but that is, I think, very much a journey.
Thank you very much. Yes, it was a complex question, so thank you.
Yeah, and I recognize the challenge that you're under, Dr. Moore, and certainly appreciate a hub and spoke type of model. I guess what we would be hoping for is that the hubs also are in essence a spoke to a central hub, a central overseeing party, in that there's always going to be variability that is out there, and some subjectivity, and what is a standard for a acute care facility may not be the exact same standard for a long-term care facility. But if we could give any feedback or suggestions, is the idea of how can that be more standardized, that the variability that we've witnessed and heard has been, surprising, let's say in the IPAC impact, and the impact on long-term care, the inability to get patients to a long-term care. You said you yourself can't recall blocking a transfer, but certainly I think the acute care facilities are experiencing that on a regular basis. And I would hope that in whatever consultations and decisions that are coming in the spring, that's some idea of how we can narrow the variability and improve the unloading of acute care hospitals. I think when we have so many patients on the wards and in non-traditional locations, the idea of not getting them back into that. And so I'll stop there. I've said too much, but I trust you appreciate what the acute care facilities are experiencing and our biased perspective on it is.
No, absolutely hear you, Dave. The ALC issue will, it's blocking thousands of surgical beds and our ability to provide care for any new cases coming through the emerge, and we'll end up with backlog into our emergency departments and further hallway medicine. So we need a summit to tackle, and if I have to write directives to help support any solutions for the alternative level of care issue, we will. And you're right about having some larger oversight. I don't want to have to write directives at a provincial level again and again and again for maintenance of best practices for infection prevention control, but will if necessary, because this office has the ability to do that central. But any feedback on best practices, I'm happy to receive them, but if you can send them to your hubs, the hub should be sending them in a coordinated way to PHO as they build back their infection prevention control table, and then can provide advice to this office, because we have a direct reporting relationship with Public Health Ontario on any necessary improvements in IPAC and or maintenance of directives. So great feedback, and hopefully the hub and spoke model can provide it back to PHO and work with this office to improve standardization.
So we certainly welcome that, and CCSO and a lot of us who work with both would be happy to help you with that. I'm going to follow up on your directive too, that I know that you say is coming off, and it'll be a two-part question. I'm just thinking of a lot of tired staff who have been ramped up, so to speak, caring for not just COVID, but the COVID-related issues and things as such, and that now that we're coming off, there is this idea that there is a backlog. Who are you garnering input on how to come off on that in terms of staff issues, but perhaps some other issues that aren't as readily apparent? I know this will be like our fifth time coming off, but I think there has been a cumulative impact on staff with it, and I'm wondering what your thoughts on that are, and then I'll have a follow-up question.
No, well, again, one of the reasons I wanted to come on was just to thank the staff for all their years of service, but in particular working in the last 2 years in a very difficult environment. So very much cognizant of the stresses and the need to take time away. As we remove Directive 2, we're in direct liaison with the leadership at Ontario Health, who are in direct consultation with the hospital sector, so CEOs and other operational leads. They have an infrastructure as well, regional leads that they're consulting with. I don't want you to think we're ripping the Band-Aid off. It will be staged, phased, cautious, and we don't want 100% revamping of surgeries. It really they have to take into consideration the current status of their intensive care unit level at a local level, regional, and larger intra-regional loads, and they must take into consideration how they can do it safely with appropriate staffing. And there are safeguards to say that you should only go back to 70% initially, and that should be a slow, staged, and phased ramp up to 70%. And then we'll give you the green light together with Ontario Health once that is achieved and the health system is still remaining balanced and our staffing is still maintained and we're not burning out staff. So I hope listeners will understand we want to do it in a staged and phased, appropriate and cautious manner. And there will be oversight by Ontario Health and oversight by us. And if necessary, we rewrite it if necessary. But we are cognizant that we're in a better state than we were 2 to 3 weeks ago. And as you know, we've allowed pediatric hospitals to resume electives, diagnostic imaging, certain screening, and that I think has gone well without any significant pull on HR issues for the hospital sector. And we're doing it gradual, phased, and staged. So I hope that's clear, Dave.
It is. It's always hard to balance the needs of the many. It's sometimes some voices people are worried may not always be heard or have the same input into yourself and that. On that theme, there was a question that was posed to us, is in terms of First Nations and Indigenous groups, in terms of both Ontario Public Health, but also in the science table. And there was a question posed, was how do you foresee increasing the input that our First Nations can put into those groups, both your public health, but as well as on the science table? So
in particular, I have leadership staff and directors in my division of the ministry that liaise directly on public health issues relevant to First Nations, Inuit, Métis, and we have very strong relationships with Sioux Lookout, as well as Moose Factory hospitals, as well as health system partners, as well as First Nation leadership. I will acknowledge, though, it's complex when you have federal, provincial, local oversight and partnership. We all have to approach it by listening to our partners, ensuring that their needs are met, and not letting jurisdiction slow us down. So I do want to acknowledge the complexity of it. I think the broader question is how do we improve equity at a population level, because we know these last 2 years have increased, in my early estimation, inequities in health outcomes across our province, whether it's First Nations, Inuit, Métis, or other high-risk communities, including our Black population. And I think we have to reflect in the coming months on our health equity approach and further embrace the lessons learned. I was very much pleased with our using health equity on our vaccination strategy, looking at the data on a daily basis across space and time of what populations have high uptake or low uptake, as well as working with our high-risk communities that had low uptake initially, but now are equitable in their immunization status. But again, I think we need to work more fully with our First Nations, Inuit, Métis as full partners, and try not to let the governance issues stop improvements in health outcomes.
Thank you. Jose?
Thank you very much. It's always dear to my heart and close to my heart, our partnership with our northern communities, as we are often called to participate and help in the care of these patients. So thank you. It is good to know that we are, looking at the lessons learned and how to move forward with these and how to improve this equity. So I'm looking forward to the development of that partnership between these complex local, regional, provincial, and federal jurisdictions. So thank you. I would like to hop on the one of the questions two of the questions that Dave actually asked. And I know that public health is the pulse of the population, and also a data surveillance driven science. And I was wondering, as we are facing our fifth wave and still uncertain what lays ahead, that we have tables of surgery backlog, but is there a measure out there, or how would we measure impact on population health of non-access to healthcare during these many successive waves? So I'm just curious to see if there is some measures or some groups that will be looking at the impact, not only of the surgical waitlist, but also at the medical patients that have not access. Thank you. May another complex question. Thank you.
Never easy. So I would look at the population pyramid. So just looking at data, we're going to be looking at all-cause mortality as a key indicator of unintended outcomes. And that the coroner system will help us with that. The medical certifications will help us with that. That takes months for us to be able to look retrospectively on the all-cause mortality. I am sure COVID deaths are a small part of the unintended, unwanted consequences of this pandemic. Anecdotally, I'm sure you've heard the delays in cancer diagnosis, delays in access to treatment, et cetera, that have caused, I think, significant morbidity and mortality in our population. So all-cause mortality would be the start. And then in delays in procedures and negative outcomes, whether it be coronary surgeries or other exacerbations of chronic underlying diseases and progression in them due to the lack of access to both primary care or acute care. All of those, I think, can be counted, tracked, and mapped. And the burden of this pandemic is much larger in terms of health outcomes than the simple numbers of COVID deaths outline. As well, we've done ongoing population surveys of mental, physical, social well-being, all of which have deteriorated significantly. And one of the key reasons I wanted to get schools back as soon as possible for in-person learning was all the evidence that was building on the unintended negative consequences of those delays. So, and then the economic impacts on the delay in education the delay in attainment of certain grades and educational levels it will have billions of dollars of impact in the coming years on productivity. So all of that, I think, is getting analyzed. I hear about it on a regular basis. And I think is essential that it will inform further and future public health responses to pandemics, to have a very balanced, nuanced, timely response to them that negates as best as possible the negative unintended consequences. So great question, near and dear to my heart, and hence us having to review on a daily basis the maintenance of public health measures, the impact on people's freedoms and rights to choose behaviors and or activities. All of that creates internal debate and debate within our division on a daily basis.
That's great.
Yeah. Thank you very much. If Dave, if you permit, just a quick question, and maybe there's no answers yet, but I was just wondering, knowing what COVID does and the long-term effect of COVIDs on multiple levels, is there anything that we are following from that perspective with the impact again on the healthcare system to try to look at it in a future way to get again that data-driven help?
Yeah, I think we're so fortunate in Ontario that we can link your immunization status plus your testing data through two large databases, the COVID immunization database, as well as the case and contact management, that can be linked into the Institute for Clinical Evaluative Studies database, which links all of the health system points of care and touch points. We can outline both costs. We can outline at a population level outcomes associated with exposure to COVID and the beneficial protection of vaccination. And we can do that across the life course. So we're very fortunate in Ontario to have that robust ability to do population level research. I don't think it's been tapped into yet, but those stories need to be told so that they inform health policy, which reorients health systems. If the rehabilitation alone of someone that's been in the intensive care unit setting with profound multi-system organ failure from COVID-19 and the ability to prevent that with robust immunization or robust access now to outpatient oral antiviral therapies, those stories need to get told.
Thank you. I'll leave it up to Dave now. Thank you so much again, Dr. Moore.
Thank you.
So Kieran, I just want to thank you for taking the time and willingness to come here. I would encourage our attendees to do their best to fill out the survey and send additional comments and suggestions for us. I would also want to ask you, Kieran, if there's any final thoughts or ways we could help you, or things that you would hope we should be aware of, and when I say we, I'm using the critical care community as a whole, and potentially acute care, that you'd like us to consider, and then some final thoughts before we let everyone go.
Well, I think as we move from response to recovery, Dave and Jose, now is the time to really start reflecting on the last 2 years, on your lessons learned, because as we move into the spring and summer, we're as a health system and as a province are going to have to reflect on how we can improve and how we can have better outcomes in the future, and how we can work more collaboratively together. And that will, I think, this government is very interested, and future governments should be interested in whether we need changes in governance, more formative collaboration and accountability, whether it's public health working more closely with health system partners, et cetera. All of that needs to be reflected and reviewed. So please, as leaders, as administrators, as physicians who have lived through this, start writing down your thoughts, because you will be asked in the coming weeks and months of what did we learn? How can we do better? how can we best protect Ontarians going forward? We've had to shut our economy down multiple times, mainly because we thought our health system would be overwhelmed with cases, because in recent times with Omicron, you may not have staff enough to care for Ontarians. I think future governments will be very interested in getting your advice, your feedback, and building the system with the lessons learned going forward. So this is a very, very opportune time to document your concerns and honestly to have them heard, because there will be, I'm sure, multiple Naylor reports, Walker reports like we did post-SARS to inform government direction and health system improvement.
So those are excellent thoughts. I agree with you, Kieran, that we'll be talking about healthcare as pre-COVID, post-COVID kind of idea.
Correct.
And certainly there is a lot to learn to make things better. And so again, on behalf of CCSO and the OC3PR community, we certainly appreciate you taking the time and effort to come here. Our next one that we are planning will be in April, barring any natural or unnatural disasters that need addressing sooner. So certainly we will be doing that. I just want to say thank you again to the CCSO group, especially for using a new format, which is always challenging for all of us. And so we certainly appreciate the feedback. I just want to close with the thoughts that I learned in particular today, and the idea of equity. And I think that is important for all of us to remember, in that sometimes we don't think something is appropriate or fair. That doesn't mean it's not right. And I think we need to recognize that your job is balancing the needs of the many as opposed to the needs of the few. And I certainly am appreciative of what you do, and along with your team. It's never a thankful job. It's like giving bad news. It's always hard when someone says thank you for telling them something like that. But I am certainly appreciative, and I've learned many things of the challenges and things as such. And I hope our audience has as well. And thank you again for taking the time. And I wish everyone a lovely day. And thank you again.